today are the common questions which we get in our minds. That is, what is a corneal ulcer? Which organisms cause infectious keratitis? How do we evaluate an ulcer? Which patients require immediate referral? And what is the basic treatment options that we have for corneal ulcers? So you would have heard these terms being used interchangeably. So can anyone tell me what is the difference between corneal ulcer, infectious keratitis, microbial keratitis? So many times these terms are used interchangeably, but there is a difference to all of these. Anyone? So what is a corneal ulcer?
The defect of the outer layer epithelium.
Yeah. So I'll show a photograph and tell me whether this is a corneal ulcer or not.
I couldn't see any changes in cornea, but something infiltrates out there.
Okay, so basically what constitutes an ulcer? So suppose if there is a small trauma or a small abrasion on the eye, do we immediately call it a corneal ulcer? You said that epithelial breakdown is important in labeling corneal ulcer. So do even in such cases, is it automatically a corneal ulcer?
No, once if it did not heal in a particular way, I think so. After putting a fluorescent dye examination, we confirm that it's a corneal ulcer or not.
Okay. So does anyone think that this is a corneal ulcer? There is a large epithelial defect, so do not exactly put fluorescein here, but there is a large epithelial defect. It's a chemical injury patient. So does anyone think that this is a corneal ulcer?
Maybe I think I seen some more under the epithelium, some more infiltrates and some first points also there.
Okay, so I'll come back to this. So the three things that essentially define a corneal ulcer is first the presence of epithelial discontinuity. As you mentioned, fluorescein staining is one of the ways in which you can actually see and measure that. This has to be associated with an inflammatory response, which leads to suppuration. So what you see as an infiltrate or as a pus point is essentially suppuration or formation of pus in that area, which leads to the formation of a corneal ulcer. So the corneal ulcer is a clinical entity which can be caused due to any cause. So one of the causes of that is infectious agents or more commonly bacteria and fungi, where it is also called as microbial keratitis. When you add to this viral keratitis, you get what is known as infectious keratitis. So there is a slight difference between all these three terms, although they are often used interchangeably, but it's helpful to know them so that you will have an idea if you look at notes from a previous treating doctor or maybe somewhere else where the patient has already consulted. So if you see these kind of diagnoses, you will know what is the difference between them. So both these cases, so the first case where there is an infiltrate, but it's not actually in the cornea. So it is an endophthalmitis which is presenting with a keratitis. So there is a corneal inflammation, but there is no suppuration and there is no epithelial defect. So it's not exactly a corneal ulcer. And then the second one, there is a large area of epithelial defect, and what you can make out are those points is actually sloughed off epithelium which is heaped up in those areas. So that too is not suppuration. You can see some amount of inflammation. So again, this is not at this stage, we would not call this as a corneal ulcer. So let us move to the next part where we describe what are all the different organisms which can cause corneal ulcers. So very commonly you would have seen either bacteria, fungi, or parasites like Acanthamoeba and viruses like HSV, which cause uh, infectious keratitis as well as corneal ulceration. So, how do you evaluate such a patient? So, what do you think is the presenting complaint which the patient will come to you with?
About corneal ulcer, yes, sir.
Yes, yes, yes,
I think boring pain, photophobia,
correct.
and some cases blepharospasm. They couldn't open their eyelids for the even examination. Also, they tightly closure.
Okay, good. So these are the two most important complaints with which the patient will come to you. That is pain, inability to open the eyes, as well as redness with associated decrease in vision. So these are some of the most common complaints that you will get. So once you have this suspicion of infection in your mind, so then what will you further ask the patient? So, can anyone connect all these things and tell me how each history is actually important to your further evaluation? So, is it important to know about whether there was any antecedent trauma or no?
Yeah, we must be evaluated. Is there any trauma in history or foreign body entry?
Okay, so characteristically, which infections are associated with trauma?
I think some vegetative straw or vegetable sticks. It could be a microbial like fungal keratitis.
Hmm.
Then foreign body basically introduces some infections like bacterial infections.
Correct. So, why is that important to ask specifically? We already asked for trauma. Why will we ask for foreign body entry specifically after that?
To differentiate the uh, ulcer is bacterial or fungal or microbial.
So, presence of foreign body entry is not exactly going to tell you which kind of ulcer it is. But remember that if you have a foreign body which has entered the eye, you need to remove it. So even though you might establish that, okay, this is a fungal ulcer and you start giving treatment, if you don't remove the foreign body, it will continue to act as a source of infection and your patient won't get better. So asking a history of foreign body entry, often what happens is that over time the patient will forget whether what exactly happened. So if you're the first point of contact for such patients, you should always ask whether something has gone inside and check immediately. Later on, when there is a lot of lid edema or reaction to the foreign body, it may become very difficult to even identify a foreign body. So, of course, all these things will lead to the cardinal complaints like redness, watering, and discharge. So, these are all important points. So, what about antecedent surgery or surgery before the onset of these complaints? So, how does it relate? So, which, in other words, which kind of infections are more common if the eye has undergone a recent surgery? So in the early postoperative period, you often have bacterial infections which are more common in eyes that have recently undergone a surgery. So it's very important to ask whether the patient underwent any kind of surgery. Most commonly in the case of corneal infections, it may be a cataract surgery or pterygium surgery or a keratoplasty as a corneal surgery. So these things will actually predispose the patient to develop an infection, and such infections are more commonly bacterial. So you should also ask the patient regarding what they are already using. So how is this important? What kind of treatment is going on? How will that help you to manage the patient better? Anyone?
uh, uh, Most of the after the surgery, if any patient is complaining about redness and discharge or watering, so in generally after certain surgery or Pseudomonas removal, we use corticosteroids.
Hmm.
So if any patient is having a bacterial infection, so immediately we have to stop that. That's why it's very necessary to know if he has gone and through any surgery or which type of medicine he is using. So it's very necessary to know
Yeah. So
to
in
treat
our
the for
yeah.
the further treatment.
Yeah, so in our country, over-the-counter usage of medications is very common. So if you go to a chemist and tell, okay, I am having pain and redness in my eye, can you give me some medication to cure that? So they will readily give you. And most commonly, what is given is the corticosteroids. So this is very important because what is so in general, if you want to take home some message, it is that steroids should not be used in any kind of infection unless it is absolutely required. So that will be decided by a cornea specialist. So in general, steroids are contraindicated in most types of uh, the infectious keratitis except for viral. So in certain cases in viral keratitis, we may end up giving steroids. But for bacterial and fungal keratitis, especially, steroids are absolutely contraindicated. So what happens is that the patient will be using some steroids and then you will say that no, no, don't use this medication. Stop it immediately. So what happens is that the steroid is actually controlling the inflammation. It is not letting the body react to the infection. So the minute you stop the steroid, the patient will have significant worsening of their complaints. So you will see that the size of the ulcer as well as the symptoms, redness, everything will increase. And the patient will inevitably say that it is because of your advice that I have become worse. So this is something that you have to be very conscious about. If the patient has come to you for the first time using steroids, if you tell them that before you visit your ophthalmologist, stop all the steroids, then the patient will inevitably say that because of this, my eye is worse. So it is necessary, but counseling is even more necessary that there is an expected worsening which is going to happen once the steroids are stopped. Okay, so the other treatment which many practitioners do is that they will give a combination of all the possible drugs, antibacterial, antifungal, antiviral, all together because they don't know which infection it is. And so they will try to cover all the bases so that at least one of the drugs will work. But if you do that, then you don't actually know, you will never know what the infection is. And if the infection does not respond to any of those medications, it will be very difficult to make a diagnosis. So you should always discourage the use of cocktail therapy, or rather, you should tell the patient the importance of getting a microbiological or accurate diagnosis for such patients. So lastly, the history that you need to ask is for other ocular comorbidities because the patient may already have something like glaucoma or may already be having a retinal issue which has already led to a previous drop in vision or previous surgeries for that. So you have to be very careful because such patients may have poorer outcomes visually. So later on, they should not blame you for starting them on the wrong treatment or delaying their treatment. So that is one important thing, and you need to treat that comorbidity as well. If the patient has glaucoma, you will have to control the pressure as well as control the infection. So that needs to be kept in mind. Second thing, as optometrists, you will frequently come across patients who are contact lens users of any type. So if you have soft contact lenses which are not being disposed in the way they're supposed to. Some people use daily disposable lenses as well for prolonged periods of time. Or if the lens solutions are not replaced at the correct time, Such patients are at very high risk of developing infectious keratitis, and will come to you with early stages of keratitis where it is very difficult to differentiate between infectious and non-infectious. So even contact lens intolerance can result in a red eye. So you need to be conscious and looking out for infection, because the treatment for any kind of allergy or any discomfort with contact lenses may be low doses of steroids, whereas for infections, as I already said, you can't give steroids. So this is probably the most important part of history taking that needs to be done at the very first visit, so that you are absolutely clear on what the situation is. Because as I said, by the time the patient is referred to a specialist, they may even start forgetting what was the actual history that they have. So we'll move to the various types of infectious keratitis. I'll show you some images of each of them, and if you can describe them, then it will be faster. So can anyone, the features are already written. Can you identify all these features? Or how many of those features can you actually identify in this photograph?
Hyperemia with hypophaeon.
Okay.
Then
So even before you start examining the patient and reach this stage, it's very important to look at the lids. So if you have swollen lids with lot of discharge and matting of lashes, that itself is a very good indicator to tell you that there is some kind of infection which is there in the eye. Along with that, if you have increased congestion, chemosis, along with a lot of symptomatic complaints like pain and redness, you will inevitably think of bacterial keratitis. So the infiltrates in these kind of cases are usually more yellowish looking, wet looking, which have rounded margins. All of these are there in the photo. So as you can see, it is a roughly circular kind of infiltrate which is quite large in size, and there is a clearing which is noted just below the area where there are two reflections. So that is actually because there is a lot of corneal thinning in that area, which we know as stromal lysis. So the surrounding cornea is often edematous because there is a lot of inflammation in the area surrounding that area of infection, and the hypopion is inflammatory. The organism cannot directly penetrate into the anterior chamber, and therefore the hypopion is usually inflammatory and it is mobile. So all these features are more characteristic when it is an early infection. So when you have a very late infection, it is very difficult to differentiate, which further highlights the fact that you need to document your notes to make sure that you can so by the time the patient is referred, they may have a progression and have like a very large ulcer which is very difficult to diagnose clinically. So when you if you see the patient at an early stage, it is important to document all such findings. So this is another case. Can you correlate any of the findings? Are there any more findings which are there here?
vessels or the blood vessels are there.
Okay, good. So what comes to your mind when you see these kind of blood vessels? So why are they not there in the first picture and why are they there in this picture? So for reference, both the infections are caused by the same organism or same type of bacteria.
I think this is chronic.
Very good. So it indicates that treatment has been going on for a long time, or that this infection is chronic. So when you refer to bacterial keratitis, usually the cornea will perforate within a period of 7 to 10 days if left untreated. So most commonly these are partially treated cases. If the infection lasts for more than 2 to 3 weeks, you will start having signs of vascularization. So any idea on what type of vascularization this is? So there are two types of corneal vascularization, superficial and deep. So any guesses on what this is?
It seems like superficial.
Correct. So whenever you have a bacterial or fungal ulcer which is partially treated for a long period of time, receiving lot of drugs which are toxic to the ocular surface, you will have superficial vascularization. As we shall see later, deep vascularization is something different and happens most commonly in viral keratitis. So, any guesses on how this is different from the first two images? So does everyone agree that this is a infectious keratitis? So you can
It,
see these
it seems like viral multiple punctates.
okay, but is there any distribution that you are able to make out here? See the superior or superior-temporal
Yeah, and yeah, here that superior temporarily there is some exudates.
yeah, so you are able to see frank infiltrates. So with viral keratitis, they will be
Yes,
very small and located throughout the cornea, or they can be located diffusely in the cornea, like only in the paracentral cornea or the central cornea. Here you can see that there is no fixed pattern of distribution. So this is all, these are small infective lesions which are there. And if you further ask the patient history, you would have come to know that this is actually a contact lens user. So when you have a contact lens user, you will have infections that are most commonly caused by bacteria, and secondly these will be a little less virulent. So unless there is a contamination of the contact lens solution, some of the surface flora or the bacteria which normally live on the ocular surface, they will actually start growing in the microabrasions that the contact lens is causing while removal or while putting it repeatedly. So this will actually cause small areas of infection, which will appear a little bit different from the dramatic pictures which were there in the previous slides. Okay, so any differences that you can find here from all the previous images?
Spanish
Okay, it is forming a kind of pannus. And
and leucoma.
okay, so there is a areas of scarring are present. So just beyond the pannus, are you able to see those two reflections and an apparent area where the cornea appears to be a little clear? Is my pointer visible?
Yeah.
So this area. So why do you think the cornea is more clear in this area?
here cornea is clear or is seems like perforating.
Correct, correct. So it is thinning out. So the
Yes, it is thinning.
yeah, so
Yeah,
because of the thinning, it appears to be clearer. So you can see, because it is becoming a desmetocele, you can see the anterior chamber through that. So clearing is not always a good sign, especially when you're dealing with active infections. So these patients will require early rehabilitation or early tectonic stabilization with a surgery or application of glue. So you need to be careful. The other thing which is not very clear in this photo, but there is a lot of deep vascularization also in the same area underlying this superficial vascularization. And you have some scarring, some areas of edema, some areas of scarring, some areas of infiltrate. with a small area which looks like it is going to perforate. This should trigger your thought to say that, okay, this is not a typical infection that we are looking at. So, I mean, for this particular case, this patient has a bacterial along with viral infection. So, these are the kind of things that you will encounter in your clinic sometimes, and you need to be little cognizant of what all you're able to see. So, whenever the image does not match the description, you should think about all the other kinds of keratitis and how it links to each other. Yes. Yeah. So to summarize, bacterial keratitis, it is usually very symptomatic. It has a yellowish, wet-looking infiltrate with rounded margins. It is often associated with lot of discharge, and you have a mobile concave hypopia. So let us go to the next one, that is fungal keratitis. So immediately by looking at the photo, are you able to distinguish some of the features that are seen over here as compared to the previous ones?
These parasites are in a stromal level. I think superficial epithelium is clear.
Hmm. What about the margin of the opacity? Is it well rounded or does it look different?
It's like feathery.
Okay, so this is what is called as a feathery margin. So if you are able to see these small extensions which are present, these are all feathery margin, and this is more dry looking. So if you compare it to the first photograph, the infiltrate appears to be dry. Okay, you also have a small area of plaque which is present. So this is all very suggestive of fungal keratitis. So this is another photo of a very early kind of ulcer. So here again you can see that a plaque has formed in the center, and there is a partially treated ulcer that is underlying it. So what about this? So can you make a diagnosis from this picture?
Panasomatis.
So this is a total infiltrate. The entire cornea has an infiltrate. So when a patient comes to you in this stage, it is very difficult to distinguish between any kind of keratitis by looking at the clinical picture alone. So these patients will inevitably they will require referral and then surgery. So you have to be very cognizant of this and ask the patient to immediately consult a specialist who can perform a surgery. So there is no point in trying to figure out what kind of diagnosis this is, because it will ultimately require a surgery. So, in some textbooks, you would have read that fungal keratitis, the signs are more than the symptoms. But in practice, what we usually see is that pain, redness, and discharge are often also seen in fungal keratitis, and these patients are also quite symptomatic. So, the infiltrate is usually described as whitish or dirty white looking or dry looking infiltrate, which has feathery margins. Also, you have small exudates at the level of the endothelium, which are called endoexudates. And often the hypopion is caused by a fungal ball which is present in the anterior chamber. And so it is a convex hypopion which you will be able to see. So lastly, we will come to viral keratitis. So here you will see that there is a stark difference, because viral keratitis is one of the largest group of keratitis which affects nearly every layer of the cornea in a different way. So first we will look at epithelial keratitis. So can anyone identify the stain which is used here?
Bengal
So one is rose Bengal, and
and fluorescent.
okay, so what is the rose Bengal staining and what is the fluorescein staining?
Dead and devitalized tissue. It's enlarged by the rose Bengal. and active tissue was known by fluorescence.
Okay, so the base of the ulcer is actually stained by fluorescein. So if you can see inside where there is an epithelial defect, that is stained by fluorescein. Whereas the edges of the ulcer, these are the infected cells. So the virus is actually infecting these cells and they are dead. So that is where the rose Bengal stain is staining. And if you can see this fluorescein which is located outside, this is because of diffusion. So if you take the photo more than 5 minutes after you instill the dye, you will see a picture like this. So actually this is the base of the dendritic ulcer and this is the edge of it. So this is known as double staining. So when you have something like this, which is a dendrite with terminal bulbs or the terminal areas have got widening here like a bulb. So these are called as dendrites. So this is known as HSV dendritic keratitis. And the treatment here is topical antivirals, which you get often as eye ointments like acyclovir. So, any idea which type of illumination is being displayed here? Which method of slit lamp examination is being demonstrated here? So this is what is called as sclerotic scatter. So this is often used for any kind of stromal lesions to determine whether they are active or not. So if you can see in comparison to the bacterial and fungal, these eyes characteristically do not have much congestion. The eye appears to be white and quiet. But at the same time, if you do the sclerotic scatter, you will be able to see that there is a small infiltrate which is located in the stroma, and alongside that there are also other areas where it has scarred. So typically you see this in cases where the HSV is recurrent. So the virus is located somewhere in the ciliary ganglion inside the nervous system, and it keeps on reinfecting whenever there is a stress or inflammation that is caused, and this results in reactivation and keratitis in different forms at any point in life. So therefore, these patients will require prophylaxis. So if you see a patient who has keratitis in both the eyes, so you should be cognizant of a few things. One is that children often have bilateral keratitis, and also patients who have atopic dermatitis or skin allergies. So you should always ask for history of skin allergy or skin rashes in response to any kind of metallic body or foreign body which they commonly use. So if you ask, especially for ladies, they may have an allergy to specific bangles or bindi, and men sometimes may have allergy to metallic straps of their watch or something like that. So this kind of history will actually help you in deciding whether that is the cause for involvement of both eyes in such cases. So this is a form of stromal involvement. So this is HSV stromal keratitis. So this is often treated with oral antivirals along with topical steroid. So again, this is also an example of a scar that has been left by the herpes simplex keratitis. So you can see in the slit there are some areas of thinning, there are some areas of edema. So all this indicates that the patient has been having this infection for a long period of time, and it has been recurring from time to time. Also, the most important thing here, as I said before, is that the eye looks completely quiet. At a single glance, you will not be able to tell that there is an infection because the eye is white, there won't be any lid edema, no discharge. So sometimes the patient themselves will not be able to tell you. So any idea why these patients are not symptomatic, whereas in other patients they are very symptomatic?
Uh, Actually, if any patient is having viral keratitis, definitely is going to lose his corneal sensation.
Okay.
So,
I also agree the corneal sensation loss.
Correct. So these patients have got reduced corneal sensitivity. So
but he will
uh,
have photophobia. Maybe photophobia was ignored by the patient, maybe.
yes, so they will have very less symptoms as compared to cases where where there is bacterial or fungal infection, because most of the nerves are affected and therefore they will have very less pain or very less amount of photophobia. So photophobia is also related to the irritation of the nerve endings. So if you have a neurotrophism or damage to the corneal nerves, that will also get reduced. So, the most important test to differentiate viral keratitis from other forms of keratitis is to do corneal sensations. So, what are the different methods that you know or use to measure or detect corneal sensations? Anyone has done?
In our clinics, we do some take a cotton sponge and dip in the saline, and we have to check it out.
Correct. So, one is of course with a cotton sponge. Any other methods? So other methods that can be used are also in the form of a dental floss. So you get a flossing string, like it's a string like thing which you get for putting between the gaps in the teeth and flossing your teeth. So that is also something that is fairly reliable. But the gold standard remains something called aesthesiometry. So you have an instrument called as the Cauchy-Bonnet aesthesiometer, which actually has a long filament which can be varied in length, and according to the length you can actually quantify the corneal sensations. So they may not always be absent in the affected eye, they may be reduced, so that has to be quantified, and this can only be done through the aesthesiometer. So if anybody is interested in doing research on herpes keratitis, then in that case we always use an aesthesiometer. So in general clinics it is very expensive to use, so it is not something that is used very commonly, but you can of course use cotton wisp to tell qualitatively whether there are sensations or not, but the gold standard is aesthesiometry. So again, this is another form of viral keratitis, which is the viral marginal keratitis. As the name suggests, it is located mainly near the margins. Again, it is associated with a lot of peripheral vascularization, as you can see. So all these things have to be kept in mind. Whenever you have an epithelial discontinuity, there can be a super infection as well. So this patient has both a bacterial as well as viral keratitis, which is leading to these symptoms. So as you can see, there is a lot of overlap between the different types of keratitis, their presentation. But if the patient gives you a characteristic history that there is some white spot which comes and goes, or it increases at some point of time associated with mild symptoms, then that would be a very typical feature of herpes simplex keratitis. So the last one is herpes simplex endothelitis, which predominantly affects the corneal endothelium. So these are keratic precipitates, which you can see again on sclerotic scatter. So these are also quite typical of herpes simplex infections. So the key points to note here are that the patients are relatively asymptomatic. They may have a recurrent course. They usually have a corneal haze or corneal edema, but there is no frank infiltrate that you can make out, unlike in bacterial and fungal keratitis. There are keratic precipitates, and an important thing is that if the anterior chamber is also involved, these patients can often present as raised IOP. So you may have corneal edema with raised IOP, which you may misdiagnose as angle closure. So that is one of the key differential diagnoses. So in most of these cases, we prove the organism using corneal scrapings. Sometimes we also use in vivo confocal microscopy if scrapings are not good enough. And we can use other advanced techniques like immunofluorescence or PCR, as it is known, to actually diagnose for viral keratitis. But the diagnosis predominantly is based on your clinical findings. So, and the diagnostic modalities are mainly for confirmation. So the treatment options that we have are mainly medical, surgical, and some which are minor surgical options or adjunctive therapies. So in the medical therapy, you treat the cause. So if it is due to bacteria, you will have antibiotics. If you have a fungal infection, it will be an antifungal. And if there is a viral infection, then you will have to treat with antiviral medications. So these are some of the common medications that are available in our pharmacies as well as in compounding pharmacies, where you can actually prescribe these for treatment. So, referral to an ophthalmologist is essential for all cases of microbial keratitis because this is a serious infection and can result in loss of vision. So, these patients need scraping and immediate treatment by an ophthalmologist. So, if you are not able to refer a patient immediately, or if the patient is unable to go to an ophthalmologist, you can start on topical antibiotics. And when you start, please don't start half-heartedly, like take 4 times or 6 times. It should be at an early dose, at least 10 to 12 times in a day. Otherwise, it is not going to be effective in such cases. If the patient is already using contact lenses, you should advise them to discontinue the contact lenses. And many times the patient will end up discarding these contact lenses. So instead of discarding, you should try to send these fluids, cleaning fluid, and the contact lens cases for culture. So sometimes, if it is a new batch of lenses which is being used and has contamination, this becomes very important for us to report back to the company so that they can check their batches for any contamination, and a major disaster can be averted. As you these outbreaks have happened in the past, so it's our duty to pick them up on time. So, any questions from anyone? Think